We are live now.
Thank you. So welcome everybody. It's good morning in some parts for our speakers, good afternoon for some, and good evening. And of course, it will be good night for the speakers who will be joining from Singapore. So welcome everybody to this Pediatric Ophthalmology and Strabismus session here. And we have some outstanding speakers. We have also kept aside some time for discussion. We also have an excellent band of discussants who can throw some really interesting questions at our experts. So I think let's start the discussions and the presentations because our speakers, some of them may have to leave. So it is an absolute pleasure to invite Dr. Federico Velez to start his first talk. He is at the Duke Eye Center at North Carolina, and he did his Pediatric Ophthalmology and Strabismus Fellowship from Julestein Eye Institute at the UCLA in California. And actually, his patient ratings and review is actually seen to be believed. He has a nearly 5 out of 5 overall provider rating. So virtually all his patients are extremely satisfied. He really has a passion for research, and he has developed many successful techniques for managing complex strabismus. And so he's the ideal person to speak on advances in squint surgery. So Dr. Velez, if you could share your screen, please.
Good morning. It's a real pleasure and an honor to be here with all of you. I really appreciate very much this very kind invitation. And of course, it's an honor to be among this group of panelists. I'm going to talk about some surgical techniques that have changed my management of complex strabismus in the last few years. These are my disclosures, not relevant to this presentation. So what about Brown syndrome? So I always thought about Brown syndrome as weakening the superior oblique. However, a lot of
your slides are not moving. Can you make it presentation mode? And
you're not seeing the slides moving?
No, you first make it the
just
mode.
go on to the full screen.
It is on full screen.
Could you just stop share and reshare? Probably sometimes it takes.
Okay. Yeah, because it is. They were moving on my screen.
Yeah.
Let me just go back. I'm gonna. Let me just go back here then. Excuse me. Then sorry about that. If it doesn't move, we can go to the second speaker and then we can go back to me. Okay, let me just go back to, because it was in full presentation. Sorry about the delay here. Can you see my slides?
Yeah.
Yeah, now just go to full screen.
And it's full screen. Do you see it?
No.
No.
Okay, give me 1 second. What about now?
Yeah,
yes,
that's right.
Okay, perfect.
Now move and see. Yeah, that's good.
Yeah, great.
Okay, great. So these are my disclosures, not relevant to this lecture. Brown syndrome, I call the paradigm. Why? Because a lot of attention is being given to this old procedure, but now going to be published in the Journal of APOS with a wonderful paper that is coming from Spain, and is what is called the superior oblique thinning procedure. So I'm just going to describe what I have learned from this procedure. First is repeat this forced duction testing in A deduction in elevation until it's free. After that is to capture the nasal portion of the superior oblique tendon and put a traction test to expose the posterior thickening part of the superior oblique that is posterior to the trochlea. At that point, this thickening portion comes anterior to the trochlea. After that, then the procedure continues by thinning the procedure. Some people call sharpening, some people call thinning. But this is what I want to kind of emphasize about this procedure. This procedure, to me, changed how I manage Brown syndrome, because not all Brown syndromes are patients that have a short or tight superior oblique tendon. Some patients have a thickened superior oblique. And if this posterior to the trochlea superior oblique is not thin, then it will never slide through the trochlea to improve the elevation in A deduction. This is not a new technique. It was first described in South America by Paulo Horta Barbosa in Brazil. And it's been popularized, but it's never really put or given too much attention of what is the importance of a procedure that can actually improve the elevation by removing some tissue that is abnormal. We're doing a study at Duke University now where we are looking the microscopic pathology of these specimens, and we have found something very interesting with an increased amount of aminoglycans inside these nodules. So it's very interesting because I believe it's changed how I manage patients with Brown syndrome. What about managing excyclotropia? So I was a person who always loved to do Harada-Ito procedures for patients that have a lot of torsion. And a few years back, we described this procedure that was a modification of a procedure that was actually presented by a group from Germany and another group from Iran. But what is behind this? Well, this is from an old paper from Alan Scott. And this paper, that was really an abstract, described how the fibers of the superior oblique not only are torsional, anterior or posterior, we actually see that there's torsion from all superior oblique fibers. This is in primary position, and this is in down gaze. Well, the interesting is that you see that most of the torsion from the anterior fibers is really in primary position. When we look in down gaze, there's actually a lot of a spread of torsional effect among all fibers from the superior oblique. So by saying this, we start working on this procedure that we call the Anterior Tuck. And you probably have seen it or read about it, but we just put together a paper where we look at long-term results of tucking just the anterior fibers of the superior oblique. It's a procedure that honestly requires minimum time, is not that invasive, and if it doesn't work, you can always go back and redo it or even convert the procedure into a Harada-Ito procedure because you're not really detaching those fibers. We're just doing an anterior tuck. What we learn from this procedure, there you go, you just tighten those fibers. So I'm just going to show our last results from a paper that was just published. And that's the portion that is taught. So what we learn with this procedure? This, and to me, this part is what makes more sense, is the stability of the procedure. Because with the Harada-Ito procedure, I have learned that a lot of the patients show encyclotorsion from the very beginning, but it takes more than 3 months for the procedure to be stable. More important, there is a significant decrease of the effect of the Harada-Ito as months pass by. So most of the patients take about 3 months to know what is the final result with the Harada-Ito procedure. And this is basically a procedure that is simple, less invasive, and shows a stability from postoperative day 1. My third procedure is what I call adjusting the incomitants and preventing slippage. So for those who like to do adjustable sutures, especially when you're working on the medial and the inferior rectus muscle, we always face this problem with muscle slippage. And also, when we're doing these fatting type of operations, but you like to do adjustable sutures, so then we have this procedure that was introduced by Alan Scott as the Resect procedure. Been doing this procedure since working with Dr. Rosenbaum at UCLA. But what I learned about this procedure is that we still see a slippage when we're treating incomitants with the Resect in the inferior rectus muscle. So Kushner reintroduced this technique called the semi-adjustable, where basically he resets the muscle, he fixes the muscle at the desired position, and the central portion of the muscle is actually placed on an adjustable suture technique for later adjustment. So the muscle can be bunched anteriorly. And this is a good technique to decrease the chances of muscle slippage. So what I introduced to this technique was a modification. Basically, is make the same Resect procedure described by Alan Scott, with the difference that I do double amount of recession compared to resection, and also do this semi-adjustable suture technique. So you basically can see that here. This muscle is basically recessed and resect, And the muscle is basically placed on the sclera at the desired position with these scleral passes. The muscle, as I said, was already resected the amount that I desired to maintain the alignment in the primary position. In the central portion of the muscle, which are these two sutures, are going to be at the original insertion, and they will be placed on an adjustable knot technique. So here you go, how the muscle can be advanced. Okay. The procedure can actually be done also very simple by placing a simple single suture in the middle of the muscle. So when you reattach the muscle on the sclera, you can use just a single suture right in the middle, and the muscle can be advanced. So I feel like it's really of help for those who like adjustable suture like myself. Okay. We're going to advance here. Excuse me. Near distance dissociation. I treat a lot of adults, and a lot of patients, for example, with Parkinson's disease, I found that they have problems with near deviations. So based on this concept of the compartmentalization of the extraocular muscles, I started working on doing surgeries for near and distance based on the upper and the lower pole of the medial and the lateral rectus muscles. And we published this recently in the Journal of Binocular Vision. But I have to give credits to other people who worked before me on what is called the slanted procedures. So the important for me is that I work on the medial rectus muscle lower pole to treat the near deviation. The same I do with the lower pole of the lateral rectus. And I work on the upper pole of the medial rectus and the upper pole on the lateral rectus to manage the distance deviation. This procedure, in my hands, has worked really well to treat patients with convergence insufficiency type of intermittent exotropia. So for example, if a patient has no distance deviation, I tighten the inferior fibers of the medial rectus muscle. If I have a patient with distance deviation, I do a slanted recession of the lateral rectus muscle. In the last procedure, I want to present, I have two quick procedures. One is a complete Turner palsy. And this comes from a discussion that I had with Dr. Alan Scott, because I felt like if we move the superior oblique, not nasally, but temporally, we can actually create a force. We're basically seeing here a patient in whom the superior oblique tendon is detached, but instead of moving it nasally, as has been recommended in the past to create basically an anchoring force, if the superior oblique tendon is placed temporally, it actually creates an abducting force. So I'm going to advance this slide because we don't have that much time. But basically what I'm doing, instead of moving the superior oblique to the medial rectus, I'm moving it to the lateral rectus muscle. And when I do this procedure in combination with a tightening of the conjunctiva medially, that can be done with sutures, or like here, with fibrin glue, we can actually see, this is a patient with bilateral Turner palsy following a neurosurgery, and he has no motility. And following this procedure that I just described to you, you can actually see how much improvement this patient has. This is the patient fixing with the right eye. This is the patient fixing with the left eye. And very interesting, you will see that he still has abducting motility, which actually to me was one of the benefits of doing this procedure. Last, this is a procedure that I call the modified knot procedure. We just published this paper. And I started doing this because I have patients like this one. And sorry for the picture, but he was squinting a lot and he has ptosis. But this is a patient that has monocular elevation deficiency in the left eye. He can really not elevate the left eye. And I did a resection of the lateral rectus because the medial has been recessed so many millimeters that I found was not worth it to try to do an ab procedure. And just by resecting the lateral rectus and doing a full tendon transposition, you can see how much his elevation and hypotropia in primary position improved. The next slide, which is the last one, is actually a patient in whom I did the same procedure. Oh, I'm sorry. Well, I'm not going to go back. But that was a patient that actually had the same procedure done in the medial rectus muscle for a hypotropia and an exotropia. So if you do this procedure, I think my slides actually even stopped sharing. Is that correct? You're not seeing my slides anymore, correct?
Yes, we are not actually.
Okay, I don't know what happened, but the PowerPoint actually dropped suddenly. So it closed the slides automatically. So I apologize for that, because my last slide was to say thank you to all of you for having me here. So that was actually the conclusion of my presentation.
Great, wonderful presentation. Excellent, some really new and thoughtful ideas as before. Professor Pradeep Sharma, if you could start some comments.
Yeah, I think it was wonderful to see some new innovative concepts in strabismus surgery. And it's like a deja vu of 20 years back that we spent some time with Dr. Rosenbaum together. So it was very nice to get back. One question I would have, for this near distance that you're doing, the upper and the lower halves, does it induce any A or V pattern? Because the slanting procedures were also used earlier for correcting A and V patterns. So does it cause some in your cases?
Well, that's a very good question. I have not seen the V patterns or even the torsion that I would expect to induce by slanting the procedure. However, I also look at this procedure this way. One of the things that, and probably some of you remember, Ed Buckley here at Duke many years back was inducing a V pattern by moving the medial rectus muscles up. So treating convergence insufficiency was, his treatment was, okay, let's induce a V pattern. Yeah. So he moved the medials up like an A, so he induced a V. So I think if we are inducing a V by doing application or resection of the inferior fibers or recessing the lateral rectus inferior pole, it's kind of the same concept that he actually had. It's possible that we induce some concomitants like a V or an A, or even torsion, but I think it's so small that probably I have not, well, probably no, I have not had a patient in whom I have induced the torsion. But you're absolutely right. I think probably the procedure works as whatever is the baseline problem, it responds. But I have seen amazing results.
Wonderful.
Federico, I was wondering, for the superior oblique thinning procedure that you were showing so nicely, do you use a microscope or loops? What kind of magnification do you prefer?
I prefer the microscope. I do prefer the microscope. So I'm not the person who knows about the procedure the most. I have to give credit to the South Americans, actually very few in South America. A group from Spain, Dr. Molinari, recently put together on the ISA newsletter a case that is coming from Dr. Merino and Dr. Gomez de Liano. And there is a paper, as I mentioned before, that is coming from the group from Barcelona, the paper is being accepted in the Journal of APOS. They have two papers actually coming up with a long-term results on this procedure. But what I want to say is the microscope is much better, because seeing this pearl tissue and thinning the procedure to get to the point where you feel comfortable that you're not doing a tenectomy on the superior oblique, because you may remove some fibers. I feel that the microscope is much better. And I will be honest with you, if you put enough strength on the superior, and you put so much that you feel you're going to honestly pull into the tendon, but you see this thickening part of the muscle just coming forward, it actually doesn't look that difficult to do the procedure. It takes time, do a good dissection. I feel that the micro Westcoats are much better than our regular Westcoat. They're so big. The micro Westcoats are much better for doing the dissection. Yeah, and the clue of the procedure, which I learned from the Spaniard group, was you have to do the force duction. That's what it changed my paradigm, because you start with a force duction test. If you can completely relieve the tension in elevation in adduction, you can proceed with this, because what happened is that the nodular thickening part of the tendon went from posterior to the trochlea to anterior. So now you can expose. And then if you cannot release the force duction test, this is not the procedure of choice, because the problem is not a thickened tendon. The problem is a tendon that is probably short, a tendon that is malpositioned, a tendon that is fibrotic. So that's how I change how I manage Brown syndrome based on this.
Right.
And in cases where you find a short tendon, which is your procedure of choice?
Well, if the tendon is short, you can do a lengthening procedure by using in silicone. If you have a tendon that is tight, but this procedure is negative, I think you have several options. You can do a spacer, you can do silicone or suture spacer, or you can do two procedures. One, David Morrison at Vanderbilt University, using techniques described by Dimber on a lab, he actually transect the tendon. You don't need to do the splitting Z lengthening procedure. There's going to be a paper coming from Saudi in the British Journal of Ophthalmology fairly soon, where they actually do a lengthening procedure. And that is basically the one that we know, where we cut the tendon and we reattach like Kushner described. But if you follow the technique by Dimber and Morrison, you can actually make two cuts that are about 50% of the tendon width, separated by how many millimeters, and that actually decreased the tension on the superior oblique between 50% and 80%. So just cutting the tendon without doing any lengthening procedure like dissection longitudinally, it decreases the tension. And if you finally have, like David Hunter described, in patients with congenital fibrosis of the extraocular muscles, a paper was published last year, a tendon that is fibrotic and short, I don't think it's even worth it to think about lengthening procedure. Those patients don't have fusion. Just cut it and let it go. The head gets straight, those patients are happy. And I would say, if you get an overcorrection, just be happy. It's like when I operate Turner palsy, that I tell the patient, if you're isotropic tomorrow, we have to throw a party together because you look we made the impossible possible. So that's how I look at these things sometimes.
Wonderful, excellent. One question for that management of third nerve palsy, where you've transposed the superior oblique towards the lateral rectus. Do you do a resection procedure also, or you just resect the conjunctiva with the superior oblique surgery?
That's a great question, and I appreciate you asking me, and I'm going to give credit to Dr. Molinari, but there's not so much time to talk. So I met with her last year at a meeting together, the last time we were in person at a meeting. And she was also doing a procedure where she actually take the conjunctiva. This is the same doctor who introduced to us this superior oblique tendon, Dr. Paulo Horta Barbosa. He does what is called caruncular fixation. I'll be honest with you. I'm working on that project and we're going to put it together hopefully soon. It's a wonderful idea, simple to do. You don't need an orbital surgeon. We can do it ourselves. I like the microscope, but when you actually do a nasal fixation of the conjunctiva, bringing basically the caruncula almost to the limbus with a good cleaning, that's a procedure that is fantastic and just releasing the lateral rectus. But what I do on the superior oblique when I transpose it temporally is basically I take it from the original insertion, I bring it over the lateral rectus insertion and the extra tendon by holding the muscle, holding the eye in the straight ahead position, the extra tendon is resected. And then alone is weak. It works, but it's weak. So I am right now doing the procedure in combination with resecting the conjunctiva, where I usually sutures, or I use the fibrin glue. Either way, I think the sutures work better than the fibrin glue.
I have a question, please. Do you do imaging in these patients with Brown syndrome, like when you decide whether you need to thin the tendon?
That's a great question. I don't do imaging for the procedure itself. I think by doing a careful first-duction testing, and if you can release it, then I think you can proceed with this technique. I will image patients just whenever I feel things are not like making any sense. For example, an acquired Brown syndrome, then I will image that patient. And this procedure can also be done, in my opinion, but it hasn't been published yet, in patients with acquired Brown syndromes that have this nodular thickening after an inflammatory process.
And one second question. When you show the NAPS procedure, how much correction do you get with just the lateral rectus transposition?
on that patient, I corrected 20 prism diopters of hypotropia. And the paper that we published have only 3 patients. It's very small, but there have been like 3 papers published in the last maybe 2 years. One is actually from Ramesh Kekunaya out of India, and he had also a paper in the Journal of APOS. So I would say, like any other NAP procedure, you correct whatever you have. It's kind of like that. The procedure, the amount of resection that I did was based on the horizontal alignment, not on the vertical. So I calculate the surgery based on whatever I want to correct horizontally. And then I just do a full tendon vertical transposition of that muscle. And interestingly, just to answer the next question that may come, I did not see torsion. And I don't understand why, but just transposing a full tendon muscle up with that much of tightening, no torsion was induced. But yeah, that's how I make the procedure.
Thank you, Dr. Velez. I know you have to go for your clinic also, so if you can be for some time, that will be great.
I am going to stay here for some time. Absolutely.
Super. That's wonderful. We love your comments on the other talk. So we have now next Professor Andrea Molinari, and she's the Program Director Fellowship in Ped Ophthalmology and Strabismus at the Metropolitan Hospital at Quito, Ecuador. She's the Vice President of the International Strabismology Association and the co-chair of the ISA website committee. And we just talked about her wonderful case of the month and her insightful comments, which we always look forward to. So to explain the complex subject of management of DVD, who better than her to tell us about? So Dr. Andrea, please.
Thank you, Dr. Rohit, and thank you to all organizers of the All India Ophthalmological Society of Ophthalmology for having me today to talk about this topic on how to decide what surgery is best for my patient with DVD. As you all know, DVD is one of the most mysterious forms of strabismus, and there have been many theories trying to explain the etiology of this disease. However, it is not the purpose of today's talk to explain these different theories, but rather to present a very practical approach on how to manage these patients surgically. So when do we indicate a surgery for our patients with DVD? There are 3 situations where surgery is recommended to our patients that suffer this disease. Patients with a DVD that is large and decompensates very frequently, resulting in a cosmetic problem. Patients that are at risk of developing or worsening pre-existing amblyopia when the deviation is frequent enough to produce intense suppression of the deviated eye, and patients who adopt a significant anomalous head posture to control the magnitude of the DVD. It is very important to study our patients thoroughly. And the things that we're going to look into these patients are the visual acuity, magnitude of the deviation, the symmetry of the deviation, presence of non-dissociated vertical deviations, horizontal incompetency, and the presence of other dissociated deviations in order to come with an appropriate surgical plan. Assessing visual acuity is very important, especially in very asymmetric cases where you're probably thinking on doing unilateral superior rectus recession. In these cases, you must make sure that the non-preferred eye will never get fixation in order to avoid postoperative problems or inversion of the deviation. The magnitude of the deviation is also very important to assess in order to plan how much surgery you will perform and on how many muscles. As you all know, DVD can be very asymmetric. Look, for example, this case of this patient that had a DVD of 20 diopters on the right eye with a DHD of 10 diopters. And on the left eye, I could not elicit any DVD at all, but he had 15 diopters of DHD. So on the second day after performing a right superior rectus recession and bilateral lateral rectus recession, a DVD on the other eye appeared. That patient had 20/20 vision in both eyes. So this is a a specific case where you can see that the patient can shift fixation and a DVD on the other eye can appear. So beware when doing unilateral surgery. So in this case, I had to perform a recession of the left superior rectus in order to obtain a better cosmetic result. As you all also know, DVD is usually concomitant. It's usually a little bit larger in abduction than in adduction, but this incompetency can be much larger in specific situations. For example, in patients with DVD and inferior oblique overaction, you will find a hypertropia that is larger in adduction, but you will also find a V pattern and fundus excyclotorsion. Patients with superior oblique overaction and DVD will show hypertropia larger in abduction, an A pattern, and fundus encyclotorsion. A larger hypertropia in abduction can also be found in patients with DVD and superior rectus overaction contracture syndrome. But in these cases, you will not have an A pattern. No fundus encyclotorsion can be seen. But you will find a very positive, actually, Bielchowski head tilt towards the hypertropic side. As you can see, there have been many surgical procedures described for treating this disease. This reflects the fact that none is completely satisfactory. Among them, superior rectus recessions, large recessions for bilateral cases, moderate recessions when only one eye is going to operate on, inferior oblique anterior transpositions. They can be done with graded recessions, augmented by resections, nasal anterior transposition, plications or resection of the inferior rectus, small recession of superior rectus with posterior fixation or with wide splitting of the muscle. Actually, in one of the recent ISA website postings, Dr. Pradeep showed a very interesting case with wide splitting of the superior rectus in a case of DVD, weakening of the foreoblique muscles, and even recessions of both inferior recti has also been proposed for treating DVD by a Mexican strabismologist, Dr. David Romero Apis. But without doubt, the most popular procedure for DVD are the superior rectus recessions. Many surgical tables have been proposed. These are the numbers I like to use for slight, moderate, or severe DVDs. And personally, I like to place fixed sutures because I think that in large recessions, the muscle might crawl back. But sometimes the problem is that in large superior rectus recession, the tendon of the superior oblique can interfere where you want to place your sutures. This is why Julio Prieto Diaz from Argentina has proposed doing hangback sutures in these cases. What I do, because I don't like hangback sutures in very large superior rectus recessions, is I place a fixed suture on the temporal border of the superior rectus, and then an hemi-hangback suture on the nasal border. I place it not on the insertion, a little bit further back, but I let it hang back. Inferior oblique anterior transposition are also popular procedures for treating these patients. It was proposed by Alan Scott in 1978, but it was described by Elliott and Nanking shortly after that. And this procedure was very popular during the 80s and the 90s, and many papers, as you can see here, have been published during that period. Inferior rectus plications or resection has been advocated as a primary procedure for DVD by the Mexican School of Strabismology, but usually it is used as a secondary procedure for recurrence or residual DVD. It should be moderate, up to 5 millimeters, in order to avoid restriction of elevation and changing the palpebral fissure. The superior rectus recession combined with Faden has also been proposed first by Cupers, and this is the original drawing of the Cupers paper. And a non-absorbable suture is used, placed it to 12 to 15 millimeters from the superior rectus insertion, which is not a very easy procedure to do. It needs good assistance. And in my opinion, it has not much advantages as doing a regular large superior rectus recession. Weakening of the four oblique muscles have been proposed by David Guyton, and it was supported by several authors, as you can see in these papers. It is especially recommended in cases with symmetrical DVD combined with a large A pattern due to superior oblique overaction. So in conclusion, DVD can manifest in different clinical scenarios, and the surgical strategy has to be adjusted accordingly. If you have cases with symmetric or asymmetric DVD and no oblique dysfunction, symmetric or asymmetric bilateral superior rectus recession is recommended. In cases with very asymmetric DVD and very deep amblyopia in the eye, which is more hypertrophic, like in this case of a baby with 18-month baby that had that was aphakic on the left eye, and you're for sure you know that the fixation is not going to change to the other eye, and no overaction of inferior oblique. In these cases, a unilateral moderate superior rectus recession between 4 and 6 millimeter is recommended. In patients with DVD and bilateral inferior oblique overaction, like in this patient who was operated for a congenital esotropia and later on developed a DVD, inferior oblique anterior transposition in both eyes is the way to go, with very stable results, as you can see here, the patients 20 years afterwards. If the DVD is very large, over 20 diopters, then the inferior oblique anterior transposition can be combined with superior rectus recessions. Patients with unilateral DVD, very poor vision in the non-fixing eye, and unilateral inferior oblique overaction benefit from a unilateral inferior oblique anterior transposition, as in this girl that had a foveal ectopia due to dragging of the optic to the macula due to prematurity. And with stable results, as you can see, the same patients 3 years post-operatively. Patients with unilateral DVD and poor vision in the non-fixing eye, but bilateral inferior oblique overaction and V pattern, as this patient with a morning glory syndrome on the right eye, will benefit of bilateral inferior oblique anterior transposition. And as you can see, also with stable results 4.5 years post-operative. Patients with DVD and an A pattern and superior oblique overaction, like in this patient that was operated for a congenital esotropia and many years afterwards developed this DVD, can benefit from different surgical strategies. I like the approach that Federico Velez suggested in these papers. When the A pattern is small, up to 10 diopters, a bilateral rectus recession is enough. And when the A pattern is moderate, between 10 and 20 diopters, you can add a posterior tenectomy of the superior oblique tendon. And if the A pattern is much larger, you can add a complete superior oblique tenectomy. Also, a 4 oblique muscle weakening procedure can be performed. And finally, patients with decompensated DVD after large bilateral recession of superior recti without inferior oblique overaction, like this pseudophakic boy that still had a decompensated DVD on the left eye, application or resection of the inferior rectus can be performed. Remember, this has to be moderate, up to 5 millimeters, in order to avoid uncosmetic results. So to conclude, there are many different surgical options to treat patients with DVD. You have to be very careful in indicating a surgical procedure for your patient with DVD. Remember that the DVD very rarely will disappear, and this has to be very carefully explained to the patient. And examine your patient very carefully in order to choose the most appropriate surgical plan. Thank you very much for your kind attention today. And let me stop sharing my slide.
Thank you, Dr. Molinari. It was a wonderful presentation on a very, very complicated topic. And we all know, as you've said, DVDs just don't tend to go away. They just keep coming back to haunt you again and again. So Professor Pradeep Sharma, your experience on the splitting of the superior rectus for the management of DVD, another option for management, and then we'll take questions around.
Yeah, I think what Dr. Molinari has shown is the basic plan that we follow. Those cases which have an inferior oblique overaction, the first choice, of course, is doing an IOAT, anterior transpositioning, because that is the most definitive procedure which works for DVDs. Those cases which do not have an inferior oblique overaction, those we may either choose to do a superior rectus recession with a bisplit, but nowadays I think we are more and more veering towards inferior rectus plication as a primary procedure. Earlier we were thinking of inferior rectus resection as a third procedure because it was always going to be compromising the anterior segment blood supply. But with the plication, which is relatively safer, I would prefer an IR plication over a superior rectus recession because it limits the upward movements and controls the DVD in a much more definitive manner, similar to the IOAT. Just like those cases which have inferior oblique overaction, we do a anterior transpositioning, which limits the anti-elevation effect, which works. The same way the IR plication, we have found, and we recently concluded a study in which we compared superior rectus recession versus IR plication as a primary procedure. And we are quite happy with that. So I would say that nowadays we may choose to do a IR plication for cases in which the DVD is more in abduction. But those which have more in adduction, the IOAT would be the preferred choice. The bisplit procedure is again another interesting procedure which I got to learn from Dr. Borgen from Germany. I'm surprised it is not much published, but we did some cases. The real advantage of a bisplit is that you can reduce the amount of recession of the superior rectus and get much more effect. So the problem of the superior oblique movement can be limited. Then you don't have much problem. You can do just about a 5 or 5.5 millimeter of recession with the bisplit, and it works as much as about 7.5 or 8 millimeter of recession.
I have a question for you, Dr. Pradeep. In cases where you have, where you already performed inferior oblique anterior transposition for a DVD, and in my experience, this procedure does not satisfactorily correct very, very large magnitude DVDs. So in these cases, you prefer to add, or your second procedure will be the plication of the inferior rectus, I suppose, and not a superior rectus recession, right?
Yeah.
And what is the amount that you usually use for performing this plication of the inferior recti? Up to which amount?
I think what you said was right. We haven't gone more than 5 or 5.5 millimeters in the most severe cases. But many times we may end up and quite successfully with 4.5 millimeter of IR plications.
Thank you.
I had a question.
Oh, I'm sorry. Go, Cameron. Go, Cameron.
Okay. For Dr. Molinari, when you say you don't like the hangback for the recession of the superior rectus, is that because of slippage you're fearing? And if that's the case,
No,
do you ever
no.
consider
The movement of the superior oblique?
No, I don't like it for the crawling because well, there was a paper published by Mike Repka when he was a fellow, so many years ago. Hopefully Mike Repka is not listening now, and he did a study in rabbits where he demonstrated that when you perform a very large recession, it doesn't happen with smaller recessions, but with larger recessions, especially recessions over 10 millimeters, the superior rectus always came crawling back. And this is the reason why I prefer to place fixed sutures.
I have a quick question for and it's regarding to resecting the inferior rectus. I mean, when we resect the inferior rectus, and I like doing that procedure, not as a primary procedure, maybe that's the way to go. What is happening to the innervational effect on the superior rectus muscle? Because you will think that you're creating some tightening on the muscle that is opposing to the one that is driving the muscle up. And it would be very interesting to know what happened to the innervational effect, because we're tethering the eye lower by the resecting the inferior rectus, but we in reality don't know if maybe the combination of both would be very interesting.
I agree with you, Federico, and this is the how the Mexicans who do inferior rectus recession explain why it works in some cases of DVD. But what I understand, or what I think, is that the superior rectus might get more innervational effect, but the tightening effect of the inferior rectus plication is stronger than the innervational effect that the superior rectus gets.
Yeah, absolutely. Yeah, and the last question would be the experience that Andrea and Pradeep or others have with anterior nasal transposition of the inferior oblique. Because there was kind of a movement by Dr. Gamio from Argentina and others that probably you would induce less anti-elevation effect when you do the anterior transposition instead of temporal nasally. And I've done it a few times. I feel that in patients that have, and this is a personal opinion, but the question that I ask is your personal experience with that. When you have a large V pattern and you're so unlucky that you create an anti-elevation, the V pattern gets much worse because then the elevation looks so bad in abduction that anyway in a deduction, there is still some over elevation that is induced by the anti-elevation. So those V patterns are much worse. And these kids are always looking at the parents up. So the parents are never happy because the eyes are still going out. Do you have any experiences with the anterior nasal transposition to manage DVDs?
No, I don't, but I would consider it only in cases where I see that there is a huge excyclotorsion in the fundus examination, because I think that these procedure together with the Aradito are the two procedures that have the most encyclotorting effect.
Absolutely. We've done it in cases of superior oblique palsy. So we've done it so we see a lot of change in the excyclotorsion. So generally what we do is if you see more excyclotorsion in the superior oblique palsy, you go towards the anterior nasal transposition. And if it's the vertical deviation, then you go for the anterior positioning on the temporal side. So probably that's how one would differentiate. And I guess we see less anti-elevation with the anterior nasal transposition. So we do see less anti-elevation. So
and to prevent the divergence which is happening on up gaze, what I do is that I do bunching and getting it in front of the inferior rectus rather than keeping it temporal to the inferior rectus, which causes a little divergence. So you should keep it in front of the inferior rectus, more on the middle of the inferior rectus. Then
and this will also, and this will also prevent the anti-elevation syndrome that Dr. Bert Kushner described.
Yeah.
Regarding the Y split, I mean, I was interested in that. So you're doing much less recession with the Y split. So that means the superior rectus remains in front of the equator, because in large DVDs, it would go posterior like 8-10 millimeters or so.
Exactly. So I don't do about 10. Maximum with the Y split I would do is 5.5 or 6 mm, and that suffices. It's like a Farden, which is much more effective on the superior rectus when we do a Y split. It works like a Farden, but a more effective Farden operation on the superior rectus.
I'll interrupt now, and I think we'll go on forward with the next talk. So we have Dr. Cameron Parsa. He trained in neuro-ophthalmology with Dr. William and Dr. Craig Hoyt, did his pediatric ophthalmology and strabismus with Dr. David Guyton, did his genetics with Dr. Irene Monami, and amazing set of experience he has. He was at the Johns Hopkins for over a decade and is now an invited professor at the National Eye Hospital in Paris and the ULB in Brussels, Belgium. And he actually graduated in physics before he actually shifted to medicine. So I hope we are able to, follow the talk that he's going to give, and it's going to be on a neuro-ophthalmic perspective on amblyopia with implications for treatment. So Dr. Parsa, please.
Thank you very much. You shouldn't ask me any questions about the physics. That was another life ago, and I don't know how to do basic math anymore. I'm going to talk about just some neuro-ophthalmic perspectives of amblyopia. Much of this work we're familiar with, and I'm just sort of organizing it in a way that makes it easier for us to think about all the things that have been learned since the 1960s, especially. As we know, amblyopia was first defined by Hippocrates, described as when the doctor and the patient see nothing, which is what von Graefe said in the 19th century. But back when Hippocrates said it, it also included presbyopia. So we see the definition was much wider than what we explained today. But the best working definition one could come up with is as a potentially reversible, thus excluding that term organic amblyopia from the literature, and generally unilateral loss of vision that results from unequal visual experience during a sensitive period. And most of us can agree with that definition today. So the essential points are that it's potentially reversible, it's due to unequal visual experience, and has a sensitive period. And this sensitive period, of course, is defined as the time that if deprived of normal stimulation or unused, the neuronal functions development will be permanently disrupted. Now, this critical period begins only once visual experience is initiated. It doesn't happen in the womb and lasts between weeks and years, depending on the species and the visual faculty in question. Neurons with more complex response properties have critical periods that end later than those with earlier process properties. So those that are in the V1, what we measure with our visual fields, those are earlier process properties and have a shorter critical period than for those in the association visual cortex, which for recognition or so forth, which have much longer visual critical periods. So we're familiar with these pictures since the time of Hubel and Wiesel, where we see that the balance of left and right cells and the striate cortex, the primary visual cortex, can be tilted in favor of one or the other eye by manipulating early visual experience. And so visual deprivation, suturing of the eyelids, for example, results in reduction of cortical cells responding to the closed eye. This we're very familiar with, and it was done in experiments with kittens' eyes that were closed shut. We could define the critical periods by monocular deprivation after various delays following birth or at the time of birth. And this early monocular deprivation, we all know, is catastrophic to the visual system because it affects many critical periods. It affects the primary visual cortex, which is in association with all the other areas. So that's the worst to have, deprivation amblyopia. And the Nobel Prize was awarded for this in 1981 for the work that was done in the 1960s in kittens. Van Noorden did this work in monkeys and macaques and showed it to be true there in primates in the 1970s. And it was one of Hubel's students, Jonathan Horton, at UCSF in San Francisco, who has continued this work from the 1980s to the present day using ever more sophisticated techniques for examining the brain cortex. And he's found some very interesting things. So remember, what Hubel and Wiesel did was deprivation amblyopia in kittens. And what we saw was the layer 4 of the primary visual cortex that was diminished. So this is monocular form deprivation amblyopia. But what of strabismic amblyopia? In that case, we see from Jonathan Horton's work, there have been no detectable changes in striate cortex that have been found. Using ever more sophisticated techniques, the changes we see in the striate cortex with deprivation, we do not see with strabismic amblyopia. And this is something that had been a bit overgeneralized before. We thought, well, amblyopia is amblyopia, we get changes in the striate cortex. Not true, that's only with deprivation amblyopia. The only changes in the brain that could be seen in about 10% of people, of animals with strabismic amblyopia was shrinkage, slight shrinkage in areas of the lateral geniculate body. And that was in the minority of those who had strabismic amblyopia. Why would we have the lateral geniculate body affected? Well, we know that most of the fibers, most of the input to the lateral geniculate body doesn't come from the optic nerve, but is afferent input from the cortex. So it's actually possible that those 10% who had slight shrinkage of the lateral geniculate body, they may have had different input from their cortex back to the geniculate body. These might have been the ones who had very early onset strabismus with very strong fixation preferences. But the 90% of strabismic amblyopia, we cannot find any changes in the brain to this date. We also know there's refractive amblyopia. And what Jonathan Horton's work has found is that there can't be any difference found in the brain, no matter how refined the techniques used in monkeys, with human subjects, incidental autopsy findings. No anatomical changes have been found in the brain with refractive amblyopia at all. So we suspect there may be subtle changes in the metabolic activity. And all this has some clinical pertinence. We know the critical periods for amblyopia in macaques is about 4 times shorter than in humans. So you have monocular deprivation before 3 months of age in macaques, that is before about a year of age in humans, that is catastrophic. But if you don't have the deprivation early on, but only up to age 8, you can disrupt binocular vision still. What we were talking about earlier with primary versus association cortex. What's interesting is that the work of Hubel and Wiesel in deprivation amblyopia was done in the 60s, the Nobel Prize given in 1981. And it was several investigators, David Taylor and Craig Hoyt, who surmised that we could get better vision in infants by operating on their congenital cataracts very early on, before this deprivation amblyopia set in. And so the first study was published with a series of children in 1981 that showed excellent acuity. And it was so good because people thought kids who had monocular cataracts just were doomed to have bad vision, and many didn't even believe these results at first. It wasn't until the late 80s that this became routine, and now it's hard for us to believe it never was the case to operate early. And again, surgery for infantile cataracts is because it corresponds to the deprivation form amblyopia that we know has a short critical period. With strabismic amblyopia, we get suppression of activity in the cells of the striate cortex, but we don't get shrinkage of the cells. That's what we see now. And this suppression is similar to that of normal binocular rivalry, with, as Jampolsky pointed out as far back as 1955, a cigar-shaped scotoma and esotropia, but where there's no amblyopia unless there's a strong fixation preference. We get hemitemporal suppression with exotropia, but again, no amblyopia unless we have a strong fixation preference for one eye. And I just referred back to this paper by Arthur Jampolsky from 1955. He's soon celebrating his 103rd birthday, and I find this is still the best paper to refer to for strabismus suppression and leading to amblyopia. We now sort of subdivided amblyopia into 3 categories with anatomic correlates that are different. And the visual acuity that we see, the difference in visual acuity is also quite different. With deprivation amblyopia, we can get hand motion vision. It can be as bad as that, or light perception. But with strabismic amblyopia, we really don't have the peripheral retina that's suppressed. We have these central scotomas or hemitemporal suppression. So we do have vision that's on the order of 20/200 or better, generally. We just recognize it's a suppression scotoma to avoid bifoveal diplopia, but the peripheral vision remains about the same. And with refractive amblyopia, the visual acuity is usually better than 2100. So we really have 3 different orders of magnitude of visual loss. One of the more interesting things, though, about refractive amblyopia that we've learned in recent years is that the anisometropic amblyopia we all know occurs when you have more than 1.5 diopter difference between the 2 eyes, does lead to a decrease in binocular fusion, which can allow for a microstrabismus that's really difficult to pick up in the clinic. And it's with this pediatric vision screening device that David Guyton developed, and David Hunter has also worked on, that can pick up deviations as small as 1 degree. But they've seen that the majority of those who have anisometropia also have a microstrabismus. So we may not just have an anisometropic amblyopia, but also a superimposed strabismic amblyopia. And the clinical characteristics of these two forms of amblyopia do differ. They're not exactly the same. The crowding phenomena that we often refer to in amblyopia, that only applies to strabismic amblyopia. The crowding phenomena, whereas we don't recognize letters that are surrounded by other letters, as well as letters that at the end of the chart are isolated areas, is due to the inability of the peripheral retina to identify targets that are surrounded by others. Foveal vision, with the fovea, we don't have a crowding phenomenon. So when we're looking with our foveas, it doesn't make a difference in our identification whether the letter is surrounded by others or not. But when it's the parafovea, that is even 1 degree off from the center of the fovea, we have difficulty distinguishing letters that are surrounded by others. So this crowding phenomenon, where we cannot identify letters surrounded by others, is not noted in the deprivation amblyopia or pure anisometropic amblyopia. So what's helpful for us to know this is it can help us determine whether we have a patient who has amblyopia in front of us, whether it's due to strabismus or anisometropia, or perhaps both. And why is that important? Because the critical periods for reversing, for treating these forms of amblyopia are different. With deprivation amblyopia, we can only hope for a benefit with occlusion up to age 4 or 5 years at most. With strabismic amblyopia, 8 or 10 years. But with refractive amblyopia, again, we don't see any changes in the brain. There really is no age limit to when we can reverse that amblyopia. So if we see a patient who has anisometropic amblyopia, and perhaps they're 16 years of age, you do want to know whether there's a superimposed strabismic amblyopia from microstrabismus or not, to know whether to treat or not, or how hard to try. So that crowding phenomenon is a useful aspect to know. So when we go back to the time of Hippocrates, when amblyopia was used to also describe presbyopia, and now we're defining it a little bit differently, perhaps we shouldn't be using the same word amblyopia for deprivation, strabismus, and anisometropia, because we have a little bit difference in the treatment plan that we develop for them. We don't use organic amblyopia for the same reason. That's an old term nowadays because it's not reversible. Just to repeat what I said earlier, with deprivation amblyopia, the model by Hubel and Wiesel that got them the Nobel Prize, there was marked degradation of the striate cortex noted. Strabismic amblyopia, nothing, and only a few instances, mild shrinkage of the lateral geniculate body. And in refractive amblyopia, no structural differences found to date. So therapy will depend on the model of pathology. If it's deprivation amblyopia, the main issue is competition, what we saw in the striate cortex, and what Hubel and Wiesel found. So the clinical consequences really patch the other eye as much as you can. And now when you have a congenital cataract and you can't operate on the child in the first week of life for logistical reasons or whatever, what should you do? Remember that amblyopia is a result of competition between the two eyes. You can halt the competition while awaiting for surgery. You can actually stop the unequal visual experience by patching both eyes until the surgery is performed. It's like putting the child back in the womb. Amblyopia only begins with visual experience. If you can't equalize it by surgery, soon enough, equalize it by closure. With anisometropia and strabismic amblyopia, there's also competition, but the main issue really seems to be disuse. We can get anisotropic amblyopia reversed even in old age. So the clinical consequence there is really try to straighten the eye to reduce the strabismus and give glasses early. These are our main approaches. Regarding congenital cataracts and deprivation amblyopia, we just said earlier, patch, patch, patch as much as you can. And yet remember that total occlusion will also cause strabismus and nystagmus, because if you have bilaterally poor vision before the age of 3 months, poor vision because you patched the good eye all the time and the other eye still has a cataract, you're going to induce nystagmus, and you're blocking fusion, so you're going to induce strabismus. So part-time occlusion for moderate degrees of amblyopia, we know produces similar results to full-time occlusion. And in these infants where you have congenital cataracts, it's better to leave a little bit of amblyopia rather than to cause strabismus and nystagmus. So do patching half of waking hours, but not the full-time occlusion, despite this theory. That's what experience teaches. One of the other things noticed more recently is that most of the visual improvement in amblyopia occurs within the first 4 months of initiating therapy. So the question is, how long should we keep trying if we don't see improvement before we declare it a failure? It's still an open question. And patients with amblyopia associated with strabismus and anisotropia, we can first give them their full cycloplegic refraction, let them get better without the patching initially. The brain can only learn so much in a day. And then when we start seeing a peaking or plateauing rather of their improvement, then start patching to boot to try to minimize the inconvenience we give to families. We also know that visual acuity in the amblyopic eye and strabismus is frequently unstable. There's slippage. Need to do more follow-up even as adults, and probably give them their full cycloplegic correction. Maybe that will prevent slippage. Try to keep the eyes bifoveal. It's hard to define the sensitive periods for strabismic and anisotropic amblyopia. It's variable per individual. Anisotropic amblyopia, we know we can still correct until death. And in terms of the treatment, just remember that it's not a single disorder, amblyopia. John Sloper pointed it out, that it's really not a uniform condition. It depends on the abnormalities of visual experience that affect different aspects of vision throughout the critical periods that are different. And perhaps we should have different terminology and call deprivation amblyopia D-amblyopia, strabismic S-amblyopia, and refractive amblyopia R-amblyopia. Maybe we should start introducing this terminology. It would make it a lot easier for students and residents to know what we're talking about before they have to do a fellowship in pediatrics. So in terms of where we are today, we realize part-time patching is pretty effective, and full-time patching is rarely required. There's only so much a brain can learn in a day. Penalization, we know, is effective in many cases, and it's always good to give the full refractive correction, or at least eliminate the anisotropic difference. There's been talk recently of dopamine as a neurotransmitter, and how perhaps giving exogenous L-DOPA to boost brain dopamine levels might improve the treatment of amblyopia. The problem with this is that we know most of amblyopia is due to competition or disuse. And so how giving an oral medication to improve something that affects one eye and not the other doesn't have a very strong basis for it. The idea was that maybe it would increase the plasticity of the brain so we could treat it for longer. But that plasticity is still so variable for individuals, it's hard to define what it is to begin with. And the problem with giving L-DOPA, which through multi-center trials, the PEDIC studies found it to be ineffective. But the problem that Craig Hoyt brought up in editorials too is that when we give exogenous L-DOPA, what are we doing to the very young child? These are large doses that are given. It might actually cause apoptosis of the dopamine-producing cells in the substantia nigra. And maybe we're decreasing their reserve of cells, and then when they're middle-aged rather than old, they might get Parkinson's disease. So that would be a very good long-term study for anybody who wants to take the patients that were in the PEDIC study and follow them 20 years from now, if someone's looking for a project, someone very young. So to learn from the past, many of the therapies previously suggested were based on reaction to previous failed therapies. And today we have a bit more of the science behind amblyopia, brain changes or lack of brain changes. And the implications for our treatment show that really it depends on our view of amblyopia, of where we should try with new therapies and perhaps avoid some like L-DOPA. And maybe a neuro-ophthalmic perspective could be helpful. Thanks very much.
Thank you, Dr. Parsha. It was an excellent presentation. I mean, really wonderful to have the neuro-opthal perspective to this. Two questions I thought, I think it's on everybody's mind. One is about Dicoptic therapy. So how would Dicoptic therapy fit into interventions?
I missed the first part of your question.
Oh, sorry. I just said that how would Dicoptic therapy fit into the interventions or management, what we are looking at? Although it's not proven to be very effective till now, but probably as we're evolving in better and better intervention techniques. And secondly, for Strabismic Amblyopia, if correcting the squint is a major intervention, would you prefer to do that before you do the occlusion therapy or amblyopia therapy? Because according to this, possibly then it could show improvement just by correcting the deviation.
In terms of Dicoptic therapy, it hasn't been shown yet to be superior to patching. So it's a very involved and costly deal to do. And there are better ones now than before, but still they haven't shown any superiority to patching. So I don't propose it yet. Craig Hoyt has written more about that, the Cambridge stimulator and others. And for the moment, patching, the simple thing seems to be the best thing. In terms of straightening the eye first, what you're saying is, in a sense, it's true. Try to straighten the eye early. And in theory, that would be better. And then do your patching and amblyopia therapy afterwards. The problem, of course, is compliance. Having the family understand that once the eye is straight, it doesn't necessarily see better. And they may be lax in proceeding with the amblyopia therapy that we know is so essential. So I think in most practices, we still do the amblyopia treatment first. Most of the improvement is in the first several months anyway. That gives us time just to schedule the patient sometimes for the OR. But in theory, you're right. Yeah.
Actually, if you're doing patching as the main therapy, then the moment you do a patch, you have removed the squint, right? So
that's
right. So that's why it's not really required to do a squint surgery first, because if your therapy is patching, but if you have to do a binocular therapy like a penalization or the Dicoptic therapy, then it would make sense to do a strabismus surgery first and then resort to the Dicoptic therapy. But if you have the patch as your first resort, then squint surgery is really no-brainer. I mean, you don't require it.
Yeah, yeah. And full-time patching, as you're mentioning, would even stop the strabismus more. It's just, as we know, we get a plateau in sort of the effect of reversing amblyopia, and then it's a question of, compliance issues.
Cameron,
yes,
I have one question
proper
about
way of looking at it.
Sorry. The interesting thing that you told us that in strabismic amblyopia, they found no changes in the brain. This was done in the experimental animals with the muscle-induced strabismus? I mean, palsy-induced? Or is it like
that was Von Norden's
model like Lawrence Tyson's?
It was I don't know, it was Von Norden who pointed that out. So in his models with macaques. And Jonathan Horton has gone about and found individual cases of well-described clinical pathology cases. He's gone so far as to transport bodies in the trunk of his car to get to autopsy them when he hears someone who's died, to look at actual human examples. And it was in Von Noorden's study where he found some cases, about 10%, where the lateral geniculate body was slightly shrunk. I don't know exactly what age the strabismus was induced. Like you said, with Tyson's model, what could induce it right away? I'm afraid I can't answer.
Because, what I was thinking, that in infantile esotropes, we know that majority of them have cross fixation, so they're not amblyopes. Mostly they have loss of binocular vision. So the binocular cells are known to be defective, as in Von Noorden's study we saw that the binocular cells were almost non-existent in infantile esotropes, whereas because they were alternating freely, the amblyopia was not there. They were 6/6 vision in each eye. So we would not expect any ocular dominance column changes in those type of cases.
Mm-hmm. Yes, and so what they saw the lateral geniculate body, they're suspecting it was those with fixation of one eye only.
Right.
I have a question. Would Dicoptic work in those recalcitrant cases in versus Strabismic Amblyopia versus the Deprivation Amblyopia?
Well, in the recalcitrant cases are basically due to the age. So Dicoptic therapy hasn't been shown to increase that critical period, or to have a longer critical period than patch therapy. So in other words, with deprivation amblyopia, after age 4 or 5, we can't get any reversal with patching. I know of no study where we can get a reversal with Dicoptic training. And with strabismic amblyopia, the critical age is a little older, 7, 8, some may say up to 10 years of age in certain individuals. Again, no improvement with Dicoptic training. One of the really interesting things with strabismic amblyopia is, is these case reports where you have someone who had deep strabismic amblyopia that didn't respond to even full-time patching, but in adulthood may have lost their good eye due to some trauma or macular degeneration. And there's well-documented improvement in vision in the deeply amblyopic eye that had been recalcitrant to treatment all throughout childhood. So there are really some issues we don't know. We can't truly define very well these critical periods, and there's a lot of questions we still have open. But in terms of practical treatment, we can't seem to, go beyond that critical age of, the first decade, whether it's using patching or atropine penalization or Dicoptic training or whatever. Maybe there'll be some subtle differences that would take losing an eye to pick out.
Thank you. I think we'll go on to the next speaker. This was an excellent discussion on amblyopia and really a new perspective for this. So now I invite Dr. John Peter Sante from Denmark, who's the head of Strabismus surgery unit at the Riggs Hospital at Copenhagen, Denmark. And he has some amazing work on the inferior nasal procedure we've just talked about, using the short tag nose technique and many other procedures. He's the inventor of the squint scope, which is a very interesting eye fixation device I had the opportunity to see when I met him last. And it's a very interesting device, and we really look forward to his talk on adjustable squint surgery.
Thank you very much, Rohit. Thank you for letting me be a part of your excellent team. I would like to talk a little bit of strabismus surgery with adjustable sutures, and I just want to show you my niece ice skating a few days ago here in Copenhagen. So we still have the winter here. But I'd like to, the squint scope is not relevant to this talk. So being a strabismus surgeon is more or less like being a sportsman. You try to hit the target all the time. And we have different targets for different kind of strabismus types. And I would like to share 6 of my patients here in Copenhagen to show you how we use adjustable sutures. So this is a 70-year-old gentleman with the right fourth. He had a right inferior oblique transposition performed. He had a residual 12 PD right hyper. We did a opposite inferior rectus recession. Then he had a small hyperphoria, was fine. Then the next patient was very similar, same surgery, same deviation, same surgery again. But this time it didn't really work out. He had a residual right hyperphoria of 10 and was diplopic. So we needed to adjust the inferior rectus 2 millimeters more. And now he was fine. So even though we have the same patients, they look the same, more or less, same age, they don't respond the same way to our surgery. And that's where we find the adjustable sutures might be an important tool to help us. So we know the different types of adjustable sutures. We know the bow tie suture, we know the sliding noose technique, and then the group in Boston with David Hunter have made this short tag noose popular, where you hide the suture underneath conjunctiva. So this is how it works. You have a little short tag noose blocking or holding the muscle. And when we move the short tag noose, then we can actually move the muscle also. We like to show our patients this model, which shows how the technique is working, and it explains them when we want to do the adjustable suture technique in local anesthesia. What's going on is we're moving the knot and we're not doing a new operation. So we have been looking at our different groups of patients. We looked some years ago at 96 patients with adjustable sutures and found that only 27 of these, that's a fourth maybe, they needed adjustment performed. So we use this for the complicated surgeries, but not all of them needs to have the sutures moved. So do we need the adjustable sutures? And if we do, are we able to delay the adjustment? So here's another patient. This is a young man, 21 years old, also right fourth, prior right inferior oblique transposition, still diplopic. He has a deviation on left gaze of 12. We did this, in this case, we resected the left superior rectus with adjustable suture. That made quite an overcorrection, and he was not very happy with this. So what should we do? Should we adjust him now? Well, actually, we waited a few days, 7 days, and looked at him again, and now he was actually autophoric. So it seems that waiting may change things, and you may avoid adjustment. So we have been looking at different groups of patients, and if we've been looking at what if we delay surgery, will this make us make things work? And another group of patients, this is 250 patients, 72 of these were complicated. They had adjustable sutures put in. 23 of them were outside target the first day after the surgery, but waiting up to a week, only 17 were outside target. So a quarter of these were actually moving into the desired amount of deviation for them. And one of the groups where we need the adjustment technique is for these Duane patients and other dysinnervation patients where you know the wiring is off. And this is the drawing from Hunter's paper of the Hunter technique for Duane type 1 surgery. You recess the medial rectus, transpose the super rectus in the same eye. And this is one of patients where we did this. We had a overcorrection after the surgery, 6 PD. We adjusted here at the third day, and this is and this took care of the problem. And many of our patients, they ask us, what if you leave so much suture material in the eye, how does it look afterwards? And in this patient, this is 6 weeks after the surgery, and the medial rectus was here, and you see the eye is quite fine, even though we left all the surgical material in there. So what about the other patients we need adjustable sutures for? This is one of the difficult groups where you have the brain trauma, maybe the Monty Python foot will come and hit you. And if this happens, we have the problem with the torsion. And we have when you have the excycled torsion from these brain injuries, these are quite difficult to realign. So what should we do here? Well, we could tighten the superior obliques like we do for the Harada-Ito procedure. But before we do this, we check how tight are the oblique muscles before surgery. So in general anesthesia, we grab the muscles, the eye on each side, like Guyton exaggerated traction test. We push the eye into the orbit to release the tension of the erectile muscles and to put tension on the oblique muscles. And this is how it looks when we do this. This is in general anesthesia. We like to examine the torsion. So we use a Mendes ring to evaluate how many degrees of ex-cycle torsion, how many degrees of in-cycle torsion. And the problem with this technique, of course, is how strong is the surgeon. So if you're a very strong surgeon, you will have larger numbers, but we try to do this in a standardized manner and compare our results with each other. So if you want to do the Harada-Ito surgery, where you advance the anterior fibers of the superior oblique, we know that there's an unwinding after the surgery is performed. So in this table, you see the ex-cyclo torsion. They suffer some ex-cyclo torsion before, and the red dot is in primary position. Then we do the left eye Harada-Ito, and quite quickly this unwinds, and you have the residual ex-cyclo torsion. So we do the other eye, and this unwinds quite quickly as well. So we try now with these Harada-Ito procedures to go for a little overcorrection. Then we wait up to a week, and then we do the adjustment of the short technique suture on the conjunctiva, and that's how it looks when you do the adjustment. So you grab the suture, you move the noose, and the tendon can be loosened or tightened depending on what the patient needs, how they desired torsion. In other groups of patients, we have found that it might be difficult to know how much we should change the muscle's length. And in A-pattern esotropia, with a tight superior oblique muscle, we do not have any table to tell us how many millimeters should you cut the superior oblique or posterior tenotomy. So we decided to make our own adjustable suture for this, and we are working now on we have data for almost 50 patients with this surgical technique. So what we do is we cut the superior oblique tendon, we put a chicken suture or a spacer, Merslin spacer in between, and then we put a short tag noose, a vicryl short tag noose, and a vicryl belt around the superior oblique tendon. So this is how it looks real time with a superior oblique tendon. It's cut, the other end is here. So you have the short tag noose, and the chicken suture or the Merslin spacer is here in between. We decided to put a belt around the superior oblique and the suture because we are afraid of cheese wiring. So the suture shouldn't cheese wire out of this because you only have a knot on this side. Here you only have the short tag noose to hold the muscle, and we were afraid of cheese wiring here. So this is the patient from before. Both superior obliques were lengthened 4 millimeters. We thought that would be appropriate. So this is what we did. But we found out that waiting a few days, this was not enough to collapse the A pattern. So we changed the 4 millimeters to 6 millimeter spacer in the right eye, and that took care of her A pattern and collapsed that. So here she is after the surgery, and we could go forward for the correction of the ET. So a few years back, I had the pleasure to visit some of you in New Delhi, and I followed Pradip Sharma in the OR to see his work on inferior oblique surgery. To put it nasally, which I was very eager to learn. So this is the normal way we move the inferior oblique muscle. We know we can put it further forward and to rise it if we want this to be a depressor. And we also, what I learned from Pradip and your group in New Delhi, which was great, was that if we put this nasally, this is the eye seen from above. This is the inferior rectus. So the inferior oblique is now moved from here to nasally. And then we are able to make this muscle work like a depressor and an intortor. And it takes care of both torsion and the elevation in adduction. And interesting, what we found here is that the anti-elevation syndrome, which you discussed before, the anti-elevation syndrome with this technique is much less than if you put it on the temporal side of the inferior rectus. So this seems quite a safe procedure, where we always put the short diagnosed suture in here to be sure we can release the muscle if it's too tight and we gain too much correction. So this is the way the muscle works now when you move it here. So doing adjustable sutures, we tried different techniques, and we learned that we need a conjunctiva to cover the suture material. So we always try to make a small incision, a fornix or a misincision on the side of the muscle. We don't usually make an opening at the limbus, because then the sutures might pop out. Then we grab the muscle, get it out, put the sutures in, measure how many millimeters we want to move it, and then we check we get what we want, and then we put the short tags, the short ends on the conjunctiva and close it up. And when you want to adjust the muscle after a few days, we found that the muscle usually would move with you back and forth when you pull the sutures. But what if you wait till the 5th or the 7th day and then you pull the suture? There is a risk that the muscle is actually adherent to the sclera and you might pull the sutures off. So then it's necessary to have the muscle hook underneath the muscle to release it from the eye, and then you can pull it forward. So we use adjustable suture for all the complicated cases where we know there might be some black box problem evolving, where we don't know where we're going. And the sutures we usually do is the resorbable vicryl or Novozyme 6.0 sutures with a noose. But for the inferior rectus, like Velez mentioned before, the Mercilin, the inferior rectus might be a tricky one to work on if you do adjustable sutures. So we now have abandoned the resolvable sutures, and we use the permanent suture, the Mercilin with the vicryl noose for the inferior rectus. And for the superior oblique, like you saw, we also use a non-absorbable suture with a vicryl noose and the belt around this. So we found that if we use the short tag noose technique, many of the patients do not need adjustment. And if we wait up to a week, many of the patients, a quarter of them, will actually move into the target by themselves. We also found that children heal quite quickly. So if we want to adjust them, we plan to do adjustment before day 5. And adults, we can usually wait till 7 days because they don't heal so rapidly. And the advantage of the wait and see procedure or the approach is we have reduced edema, the stretching of the tissue is demasked, and also this makes a great flexibility for us, for the doctor and the patient, to find a time for adjustment which fits in our busy schedules. So thank you for letting me share some ideas on adjustable sutures, and happy Shivai Jayanti holidays in India. Thank you.
Thank you, John. That was an excellent presentation on adjustable sutures, and amazing amount of muscles that you have now put on adjustable. So again, very interesting presentations, and I'm sure a lot of our listeners would be interested in shifting to adjustable surgery. So Dr. Pradeep, yeah, Dr. Cameron, yes.
One comment I wanted to make, you spoke about doing delayed adjustments in children and adults to wait for the edema to go, and that in adults you could wait up to a week because it doesn't heal so well. What Arthur Rosenbaum used to do is inject a little dexamethasone at the time of surgery too. So that would prevent the stickiness. So if he wanted to adjust a day later, which he routinely did, or Federico could speak more about this. If you want to do a delayed adjustment, that does help. I've tried it a few times, and it does make a difference. You don't want to inject a long-acting steroid, of course, because then you'll never get healing, and you'll get the sutures dissolved and a slip muscle.
Yeah, I agree. That's a good point. Thank you, Carmen. Yeah, actually, we have not tried the dexamethasone for this, but another comment on dexamethasone is one of my colleagues in the glaucoma and the cataract group that found that the kids are very the reaction to all kinds of steroids might be quite surprising. And some of the kids with a congenital cataract developed Cushing syndrome from eye drops only. So we are actually moving a little bit away from steroids now. Also in my group, we're actually putting up a study to look at if we can avoid steroids after the surgery to just give them antibiotics. Because we have some of the patients, especially the kids, if we measure the pressure a couple of weeks after surgery, some of them have pressures in the 30s. And it always surprises us when we find this.
Right, but does pressures in the 30s for a few weeks do any harm, really?
Well, you don't know. And sometimes they just go to the pharmacy and get another bottle because the eye's still red. And so well, we're a little bit worried about the steroids, actually.
I think sodium hyaluronate also has been used by people for delayed adjustment. You can just apply a layer of that prevents, and that will get absorbed by 24 hours to 48 hours. So that's something which may be used. As far as the steroid thing is concerned, we did a study which about a few years back, and we were surprised to see that dexamethasone does induce in 2 weeks' time. So we were earlier not taking pressures in our children whom we put post-ops after this strabismus surgery. Now we have started taking intraocular pressure after 2 weeks. And those who are having a rise in intraocular pressure, we switch them to either fluorometholone or a non-steroidal anti-inflammatory.
By the way, when I mentioned what Rosenbaum did, it was just a small sub-tenons injection at the time of surgery. It wasn't continuous drops or oral steroids. It was just at the time of surgery, the last 24 hours.
Yeah. Before, we usually did, we injected bupivacaine under the conjunctiva after the strabismus surgery to take care of the pain. And I found this quite disappointing when you use a lot of time to suture the conjunctiva and it's neat and nice, and then you inject something underneath and it balloons up and it ruined your nice work. So actually now we use eye drops instead. We use oxybupropion eye drops, and we found in a study that just 1 or 2 drops of these oxybupropion eye drops just after the surgery, before we wake the children, will reduce their need for opioids, for morphine, by 80%. Just a small eye drop.
Addition. That's a good one. Yeah.
So thank you, John. It was an excellent talk. We'll go on to the next, and I welcome Dr. Audrey Chia from Singapore. It's very late night for her, but thank you very much for coming. And she's the head of Pediatric Ophthalmology and Strabismus at the Singapore National Eye Center. She did her ophthalmology training at the Sydney Eye Hospital and the Pediatric Ophthalmology at the Great Ormond Street, London. And of course, besides a profound knowledge of myopia and key role in the ATOM studies, she also runs the Visual Electrodiagnostic Lab at the SNEC. So no one better to talk on childhood prevention and management strategies for myopia. Dr. Audrey, please.
Sorry, just muted. Oh, what's happened here? Let me just try that again. Can you hear me?
Yes, we can.
Excellent. Okay, so thanks for the invitation. So I'm talking a little bit about myopia, prevention, control, and management. I think that was my topic. So the question is, why are we doing this? We all know what causes myopia. The eye is growing too big and it's stretching, and we're doing it because we want to avoid complications from high myopia, which occurs usually later on in life. So things like early cataracts, retinal detachment, glaucoma, and macular degeneration. So the myopia epidemic began very early in my part of the world, in Singapore and South Korea, Taiwan, Hong Kong, where you see that way back in the 1980s, 1990s, you saw this rapid increase in myopia in the population from around about 30% right up to around about 80%, and it still remains there, although in some countries like Korea, it's gone up to 90% now, whereas in Singapore, it stayed more or less at 80%. And what has caused this is actually a change in lifestyle. So we know it's mainly environmental, 70% is a combination of academic pressures, not enough outdoor activity, too much indoor, and also genetics. So we know if your parents are myopic, 1, it's 3 times more risk. If it's 2, it's 4 to 5 times more risk. So there's 2 components that cause the myopia. So from our studies in Singapore, our 7-year-old kids, around about 30% are short-sighted, and then by the time they reach 12, it's 60%, and by the time they reach 18, it's 80%, with 20% being highly myopic. And this is not only a problem. I know in India also there's increasing rates of myopia as well, and we expect that studies predict that by the year 2050, about 50% of people around the world might be myopic compared to around about 20% now. And this, we worry, will result in high myopia, and high myopia will result in more complications. So the challenge we have is to prevent onset of myopia if possible, and delay it as much, delay the progression as much as possible once it's occurred, so as to prevent high myopia. So how do we do it? We can do environmental things. So there's a little poster of what our health promotion board sort of like puts up, keep myopia away, go outside and play. So, and we have this up on our rooms. It's a very old one. And at that time we were more saying, okay, less computer and handheld games and stuff, but also includes reading storybooks as well. So we say, don't read so much storybooks. And if you do, make sure you have bright lighting and take breaks and stuff like that. So that's to try and prevent onset. Because what the studies do show is that if you have high amounts of outdoor activity, which is front row here, you actually can do more near work and still have low rates of myopia. So outdoor activity seems to be very protective. And why we came up as 2 hours a day is because of this study by Rose et al. In 2009. And the average Australian Chinese kid has a myopia rate of 30% at 12 compared to 60% in Singapore. And they spend 14 hours a week outdoors in Australia, which is 2 hours a day, and only 4 hours a week in Singapore. So that's the difference. So our recommendations is at least 2 hours outdoor play per day. Hard to achieve, unfortunately, in our country. So we know 2 things. It does increase the onset of myopia, and it also does decrease progression of myopia, but to a lesser degree. You look at the meta-analysis, it's not that impressive, but we still tell them, for progression, but we still tell them it also is important once they have started being myopic. Lately, people are talking about using technology to slow it. So we have things like a watch to monitor light intensity. And we know that if you go out to play, it's very high light intensities outside. So we can have the watch and that can monitor the outdoor light. You can see here in Singapore, there's 2 peaks, one when they go to school and one when they come home. So it's pretty pathetic. And we also have apps that you can use that can monitor time that you spend on the device. And in Singapore, we got this app which links to our reward points, so that if they do all the tasks, they can exchange their points for a little gift voucher in one of the shops and things like that. So that's to help them, incentivize them to not use their phone so much. So in terms of glasses, there's different designs of glasses through the years. I usually call them the old generation ones and the new generation ones. So the old generations ones are things like progressive glasses, bifocal glasses. And we know that the cost of these are quite moderate, but it's safe. Glasses don't cause any problems, except maybe a bit of distortion when they look down for these glasses. But the efficacy was very variable and not very good. So in the past, we say, okay, you can try it, but it may or may not work. Generally quite well tolerated in children, but sometimes with the progressive ones, the kids don't like the line at all. They just will not wear it. So it's sometimes difficult to get them to wear the progressive. More recently, you got the peripheral defocus glasses. These are more class F, just like 360 on the outside, and there's the clear design. But unfortunately, there's now 2 studies that show there's very little effect. And so it's not something we really push at the moment. But just last year, I'm not sure it's available yet in India, but last year in Singapore, we now have these new generation glasses, which has little positive lens slits at the periphery. So one of the problems with the clear lens was, children might be using the wrong area. They might be looking through the clear area rather than the center area. But here they have to look through the clear area. And because the periphery is slightly blurry, and that will hopefully maintain them in the treatment zone. And the study, there's only one so far, so it's quite a good efficacy, but perhaps in older children, and there's still not a lot of evidence because the study starts from 8 years onwards, whether it's effective in younger children, and I have few that don't seem to work so well in younger children, and also whether it's effective in high ranges of myopia and astigmatism. Parents always ask me, how about pinhole glasses and blue blocking glasses? And there's no evidence, I think, of those devices at the moment. The other one is contact lenses. And contact lenses, you got the daytime single wear hard contact lens, soft contact lenses, and those have no effect. But there are also daytime multifocal contact lenses and a whole range of study ranging quite far back, variable kinds of degrees. The most, I think, one that has shown the best effect is the MiSight daily disposable contact lenses. But we do know that some kids can't tolerate it, and there's for some of the contact lenses, there's limited amount of astig that you can correct and limited amounts of myopia that you can correct. So there's a limit of that. Also, you got the autokeratoplasty lenses. These are ones that you put at night to sleep, and it just compresses the eye and decreases the focus of the outside. So it does create sort of like plus zone on the outside as well. These are quite expensive in Singapore. I'm not sure how much they cost in India. And the efficacy varies. It seems to be best in the first year and then declines a bit over time. There's 10% that do not respond so well. And also it doesn't, it can treat maybe up to 500-600 and less than 2 diopters astig. But other than that, then you might have to supplement it in the day with glasses. Because the risk of contact lenses is also the infection risk that we always worry about. And there's one study with the OK lens that when they stopped it, there may be also some rebound that we need to warn the parents about. So the thing about contact lenses is that some might not tolerate it. And also we have to be very careful and watch for infective keratitis. The other treatment is, of course, the Atropine Drop, which I sort of like have been using for the last 25 years. And there's low doses, which people are controversial what you consider a low dose. It can be anything from 0.01 to maybe 0.1. And then you have higher doses. And of course, as the dose increases, you get more side effects. In Singapore, it's relatively cheap, but I know some places in the world it's very expensive because they compound it. The efficacy ranges in all the studies. There's a little more studies of lower, anything between 30 to 65% for these ranges. And when we find in our group that if we start in a very low dose, that about 20 to 30% will need to have a higher dose. Either we have to increase it a little bit. And this is especially true in the younger children and those of, where high myopic families and things. So we sort of like say, okay, I might have to increase it. You warn them first before you start. So generally in our population, the low doses are pretty well tolerated, but we also need to keep an eye on axial length because there's some evidence the effect on axial length may not be as good as peripheral equivalent. So we do both as our measure, but unfortunately some places don't have the axial length, so it can be a little bit difficult. The high doses is our last resort. It's the most powerful kind of thing that we have at the moment. It goes up to 80%, sometimes even get a hyperopic shift. But even 80% is 10% that will respond fully. So there is a small group that will not respond to atropine. And these children will need your tinted glasses and near air because they're going to get near blur and glare. And we have to be very careful with stopping because they will get a rebound. So I normally do a very slow taper as I take the kids off these high doses. The other most common side effect is allergy. And lately, there's some studies that show some additive effects between contact lenses and the atropine. And the question is whether it's the same for glasses. I don't think there's any study yet about the glasses and atropine. So I've shown these graphs before, and these are how I plot it. Each little box is 6 months, and these are the ages of the children, and you can see the progression. And when I start, I watch to see what the spherical equivalent is going, and also the axial length. And then after they're very stable, I try to slowly taper off if they're younger than 12, and then more quickly after 12. And hopefully they stay steady. If they're not holding, you sometimes need to increase the dose, although nowadays I sometimes offer them glasses rather than increase dose if they want to try that. But I'm not quite sure what the effect is. I'm still waiting for the results to come back, but maybe it's something we can use in the future. So the considerations when you manage the children is how old are they? Are they young? Are they old? Because they're younger and they're quickly progressive, then they're going to be highly myopic. Whereas they're older and they're slow, then maybe you don't need any treatment at all. Okay. You talk about the family history. Is it very high? Is there a lot of complications? So this make parents a bit more wary about high myopia if they themselves have retinal detachments and stuff. Whether they are able to tolerate your treatment. Do they have a lot of eye allergies? They got very bad blepharitis, and they really got phobia to drops. They really, cannot tolerate it. And some social factors, what they prefer in terms of the design and the choice. In terms of your treatment factors, you must see what's available in your country, and there's sometimes not all the choices are available. You need to think about what the efficacy is, and always the efficacy is not going to be so good in the younger children, and what the degree is, and whether you want to be really aggressive or not, how your safety and tolerance levels are, and also what your cost level, cost sort of like how much the parents can afford kind of stuff. So those are factors also that are important. So in your initial visit, I sort of say, okay, how old are these factors? And I predict, is this child going to be highly myopic or not? And then it's a discussion with parents. Do you want to start on what you want to start? Or do you want to wait if it's very low and see what happens? Of course, if it's very highly progressive, then you sort of say, okay, this child's going to be highly myopic, especially very young, starting already. Then you might want to start treatment because it's something that once it goes up, it's never going to come down. So the earlier you start, it means that the lower degree is going to end up at the end. So you talk about all the different choices. For younger children, sometimes the drop's easier because you just put the drop in, but you need to be aware of side effects. And the drops are in a way good because if they're not working so well, you can always increase the drops and increase the dose. Whereas the glasses and contact lenses are more or less all or nothing. It either works or it doesn't work. Okay. So the glasses, the cost is not too bad, but the early generations may not work. But the newer ones, we still have to wait to see because it's very, very new. But it looks promising. So hopefully it's another weapon in our armamentarium to sort of fight against this condition. But there can be some blur, and sometimes the kids are a bit worried about appearance, although it's not too bad if the lenses, it's not very obvious at all. With the contact lenses, of course, it's the most costly. And of course, if you've got a lot of allergies and very bad hygiene, you may not want to start these kids on the contact lenses because of the risk of infection. And then if anything you start, the question is whether you want to combine. So atropine is very good for combination, especially the low doses. When you use high doses, it's a bit tricky because that itself causes blur and things. But with the low doses, it's an option to combine it with something. Although the effect of this yet, I don't think we fully understand, but it's something I'm going to try, and maybe in about 2 years, I can let you know. I'm sure other people are doing it too. So how do we monitor? I usually monitor 6 months. Some people do more frequent, some others. I look at cycloplegic refraction. I also look at axial length, and I see how they go. And then the question is when to stop. Okay, so when it's sort of like not progressing anymore, when it's stable. And of course, if it's older, it's always safer to stop at older. So even with atropine in our study, with the low dose, we found that if we stopped at age 8, 60% will still go up. If we stop at age 10, it's 30%, it still go up. If we stop at age 12, it's only 8%. So it's safer to stop when the child is older, whatever treatment you're on. And I think it's something you need to really explain to parents because they think it's, you start and then you can stop 6 months later and it's okay, yeah. Especially with rebound effects of some of the treatments. And I think that's all I have to say. Thank you.
Thank you, Dr. Audrey. It was an excellent presentation. A lot of doubts about current management of myopia. We, of course, have the low-dose atropine 0.01% now commercially available quite easily all over the country. What are your thoughts on the LAMP study where they've talked about 0.05 being probably more effective? I mean, of course, you've said, and we know that it's a dose-dependent effect. And you obviously, as you increase the dose, you may increase risk of side effects, but efficacy may be more. But would that be a better, kickoff between side effects and efficacy?
Yeah, I think it's definitely gives you the option kind of stuff of what dose you want to start. In some of the Caucasian populations, I think they find that maybe the 0.05, they get a bit more dilation and glare and things. But I think in our Asian population, it's probably going to be a lot better because we use the 0.1 quite a lot, and I use it 3 times a week, sometimes as a next dose up, which is equivalent to 0.05. And 50, 50, you know, some of them are really okay with it and they don't need any glare or whatever. Although you look at pupil, they can be quite large. And I think even with the 0.01, sometimes the pupil is quite large. And so with the 0.05, it can, but in our Asian eyes, you can't see, you know, it's not like a Caucasian eye when it looks really funny, you know, so if they don't have any glare, you might not even know that they are on the drops at all. So I think it's a comfort level and what you can get. I think in the older kids, the 0.01 is probably okay. But for the younger kids, then I think the question is whether you want to start with a higher dose, or you can sort of work your way up very quickly. If you got a variable dose like 0.1 not working, then I'll just go up, you know, quite quickly to the higher doses and then go from that way. So it's possible, yeah. So I think it depends on what you have available. I think my next thing I'm going to try, because we've got the 0.025 coming up in our center, is probably for some of the younger children do that, because I know that that will probably have less side effects than the 0.05. So I probably will try that in the younger kids, because sometimes the younger kids now, I just give them 0.01% twice a day, straight away kind of stuff, rather than do that if they're really like, you know, really highly progressive, rather than wait. Yeah.
May I pose a question, Dr. Chia? If you have a child that is 3 years old and has a plano cycloplegic refraction, but parents with or family history with myopia, would you start preventive treatment? And if you do, which dose would you use?
That's the topic of ATOM 3, okay, which is a preventive one, which we are recruiting at the moment. We really need to end recruitment this year. So we maybe can give you the answer in another year's time, yeah, about what we found. It's currently double-blinded, and I can't access the data yet. But I think if it's really preventive and the very low dose that has very little side effect works well enough, then it's probably the way to go. It's, I think, hard to justify a higher dose for a child that is not even myopic yet. Having said that, I know there's some people that give children not myopic 1% straight away, you know, kind of stuff. So there's various ways of thinking about it and things. But yeah, it'll be interesting to see whether we can prevent it and in what children do we use it, because, you know, who is considered high risk and is the possibility, because in some families you say, oh, mom's really high, dad's really high, one kid's really high and the other kid's fine, you know, kind of stuff. So how can you really sometimes predict sometimes? So but yeah, I think it's an interesting question. The other question is whether you want to give glasses or contact lens as a prophylactic measure. And I think that's also the other options that especially glasses, is whether that will come up as a possibility or not. Yeah.
Dr. Chia, I would like to ask one question. Would you wait for the documentation of progression before starting atropine, or would you give it in the first shot? Because in India now the trend is they get their first prescription and a prescription for atropine together. Is it right?
Yeah, I know. I mean, I got a few Indian children, first generation myopes in Singapore, that really are so hard to control. I don't know what they're doing at home. But yeah, I normally sort of like, you know, it depends, because once you start, you sort of almost committed for quite a long haul. So I really want to see some progression before I start, you know, because sometimes, especially some kids come in and you say, wow, they're 500-600, and then they don't change, you know. So I like to see it. But if there is sort of like, oh, I know last year I wasn't wearing glasses, I passed my school test, and this year I've really, you know, gone up to -3, then maybe I'm more inclined to start. But I'd like to at least have some increase, yeah, before I start. But I'm sort of flexible if the parents are really worried.
One more question here in this regard. We see a lot of premature children who have nothing else except myopia. Would you recommend atropine for them also, or do they behave the same way?
Yeah, do you find that the ROP babies sometimes they sort of like don't change very much though? They sort of like, quite shocking sometimes. 1,000 when you first refract them at sort of like 6 months old, and then they can be quite stable after that. So my idea is that I think the pathogenesis is a bit different because it's if I understand correctly, it's because the front bit is sort of not growing as well as the back bit because of your treatment with your laser and whatever. That's my simplified idea of what it is. So the question then is not really a big eye, it's just the lens apparatus is at a different position. So then a little bit of growth behind can suddenly result in a very high degree. So I sort of like, I'll probably watch. There is some small population of them that then start going up a lot, and then it's a discussion, maybe we'll try it, but there's no good evidence that it works. So it's one of those I'll try and see kind of things. And then the question then is what dose if it doesn't work? Do you keep going up or not, or stop and things like that? Yeah.
Yeah, we've seen some patients of ROP where myopia increase in spite of giving the 0.01% atropine. So yes, you're right. I mean, the mechanism is different. I mean, I have a question. What about the patients like post-cataract surgery who have a myopic shift? Would it help in preventing those myopic shift in post-cataract surgery?
Oh, you mean in children with child with children? I think it's a study that you can do better in India than us in Singapore, because we don't get so many congenital cataracts for some reason, kind of stuff, yeah, we got vaccination for rubella and stuff like that. So our rates of infantile cataracts are actually quite low, to say, and basically, I think by the time you sort of like find the myopia increasing, it's sort of like they're 3 or 4 years old, and then they're quite high already. I think it's still, you could try it again, but again, because I have so few patients, I cannot really say. Yeah, but it might be something that in India we have so many that you could try it and see what happens and let us know.
Dr. Jitendra Jethani would like to add some perspective, Indian perspective.
Yes, actually, we have around 7 patients in pseudophakic patients, in which we used low concentration atropine, and it does work. Just a quick comment on the ROP children. So a lot of ROP children actually don't progress. So we really are looking here for usage of atropine when there is a myopic progression. So normally with children who are myopes and do have a history of prematurity, we normally try to wait and see whether they are progressing or not. But my experience is different from Jaspreet. We have used in some of the cases, and it has worked. In a couple of cases, at least, it has worked where there is ROP and they have axial myopia. They don't have they don't have a normal sized eye. And yes,
my thoughts are, if the front bit's very narrow, then it doesn't need a lot for it to go out at the back, that you suddenly have a huge degree because of the optics and stuff. It's almost exponential, right, in a way. So yeah, so I'm glad to hear that. I mean, that's really good. Yeah.
So thank you, Dr. Chia. I think we'll go on to the last talk of this session. That is by Dr. Prem Subramanian, and he is currently at the University of Colorado, and he did his fellowship from the Johns Hopkins. He is an outstanding neuro-ophthalmologist, and I would say that any neuro-ophthalmologist in India would have definitely heard him, learned a lot from him, from his outstanding and most interesting talk. So we have him today talking about pediatric optic neuritis, which truly is quite a difficult thing to manage, and quite a difficult thing and a different thing from adult optic neuritis. So Dr. Prem, if we could. Dr. Prem, you're mute at the moment.
Sorry about that. Thank you. Happy to be here, and I'm going to use a few cases to illustrate what Dr. Saxena was just talking about, is the fact that this has some similarities but definite differences with adult optic neuritis, and give some discussion about how we manage these patients differently. So the first patient is an 8-year-old boy And he noticed that he had a blind spot in his left eye, and he was otherwise healthy. He lived with his biological parents. He has several siblings. They're all in good health with no chronic medical problems. A cat and a dog live in the house as well, this being a good American household. And his vision was normal in his right eye, but markedly decreased to the 6/120 level in his left eye eccentrically. He had a left relative afferent pupillary defect. His color vision was normal in the unaffected eye, and his visual fields by confrontation looked to be normal in the right eye, and he had a dense central scotoma in his left eye. Now, the first point I'd like to make here is that doing perimetry in an 8-year-old is often successful. I have been able to get reliable perimetry in children down to the age of 5, typically girls more than boys. But by age 8, I, again, with a good technician, have had good success with a CETA fast protocol, which really should only take 4 or 5 minutes. And especially with kids, relative to the prior talk, spending a lot of time on screens and being very familiar with games and such, they will treat it as a game and generally do pretty well. This was not the most reliable field, but we can appreciate that there is an apparent inferior scotoma in the left eye, along with that central depression that was picked up by confrontation. The right eye, it's unclear if that depression is abnormal or not. Remember, though, in the optic neuritis treatment trial, we did find that 1/3 of unaffected eyes did have a visual field defect. We don't know if that applies to children or not. And speaking of the optic neuritis treatment trial in children, so this boy has a swollen left optic disc evident here, and on the right it is normal. It is quite frequent that we see papillitis, a swollen optic disc like this with obscuration of peripapillary vessels, peripapillary hemorrhage, as can be seen here in the papillomacular bundle, and additionally some evidence of congestion because of the venous tortuosity. All of these features evident just in the left eye, not in the right eye. So how are we going to proceed with this patient? Well, you can see that there might be a little fluid in that papillomacular area as well. And in the OCT age, we can appreciate that that's actually very significant here, that there's marked subretinal fluid. And one thing we see in children is more of this crossover between the idea of a pure optic neuritis and potentially a neuroretinitis. And then on the MRI, the arrows point to the fact that there is a very specific and focal enhancement at the optic nerve head itself, a papillitis, again, without really much enhancement far back in the orbit. So the arrow in the lower coronal section is pointing again to just behind the globe where there's a tiny bit of enhancement, but otherwise nothing else. And the brain MRI was normal. So in this case, where you have a fairly young child, 8 years old, first decade of life, who has vision loss, papillitis, and no other systemic features, what are we going to do? Well, this is India, so I figured TB was obvious, so I didn't put that on the list. But we would test for TB. Syphilis, unfortunately, can occur at any age as well, so that's important to check for as well. But the typical agents, Bartonella, looking at that neuroretinitis crossover spectrum, looking for evidence of sarcoidosis. In certain parts of North America and Europe, we'll look for Lyme disease. In Colorado, where I am, Lyme disease doesn't really exist. And toxoplasma. Some people suggest toxocara, but I've never really seen that produce a true acute onset papillitis in an 8-year-old child, more of a congenital problem there. And is there evidence for treatment with a negative workup? How are we going to manage a patient like this who has an optic neuritis? Maybe it is idiopathic. We find no other positive test that points to an infectious or other inflammatory etiology. I alluded again to the optic neuritis treatment trial. There is work underway to try to do a pediatric optic neuritis treatment trial to see if IV corticosteroids have the same benefit and if they affect visual outcome down the road, but we don't have that same kind of strong prospective evidence. That said, the use of corticosteroids in patients with pediatric optic neuritis, at least in North America, has become fairly routine, and the outcomes again are being measured right now. But there are a couple of things I think that still plague us with optic neuritis, particularly in the youngest children, and that is that the time of onset can be harder to determine. Pain is often not present, it's worse with eye movement. And again, the child may not report the visual decline until it becomes fairly profound to the 660 or 2200 level or worse, or when the second eye is affected. And there again are no good data to back this up. But I have always wondered if the fact that we see more bilateral optic neuritis in younger children has more to do with the fact that younger children may not care if they can't see out of one eye as long as the other eye is still seeing okay, and don't report that problem to their parents or isn't noticed. And it's only noticed when they lose vision in both eyes and then start to be able to perform activities that they normally would. So I think a question that might be hard to answer. But if we look at the outcomes of pediatric optic neuritis, what we know from retrospective studies is that the visual field defect is similar to what we see in adults. It can be virtually anything. Their time to recovery may be longer. They may continue to recover for more than 1 year, unlike in adults where we tend to see that visual improvement plateaus by 6 to 12 months. And visual recovery is usually excellent. So one observation has been that pediatric optic neuritis in general, the visual acuity at presentation may be worse, but the recovery may actually be better compared to adults. And almost all of them seem to get back to excellent visual acuity. We'll talk about the exceptions. And recurrence is variable, and we will get into that as well with the next two cases. The second case is a 14-year-old white Caucasian girl with Northern European extraction who had pain with eye movement in her right eye, and then about a week later noticed some dim, blurry vision as she described it. She, like the previous patient, was also otherwise healthy, had no other ocular or medical history. She was doing well in high school. She had no pets at home, and she had a cold 2 weeks ago. This was in the pre-COVID era. And her vision in the right eye is mildly reduced to 618, normal in the left eye. She has a right RAPD, and her color vision by Hardy-Rand-Rittler plates was diminished in her right eye only. And the remainder of her anterior exam was unremarkable. At this point, she said that her pain with eye movement, while it was still present, wasn't really what bothered her. What brought her in was the fact that her vision had declined. She did a nice, reliable visual field, and in her left eye, the unaffected eye, it is normal. And in the right eye, we see not that different from the 8-year-old I showed you. There's a decreased foveal threshold. There is, in this case, a superior, somewhat altitudinal defect, along with evidence for a central or secocentral scotoma. So characteristic of what we see in patients, adult patients with optic neuritis. And her fundus exam, there's perhaps a little bit of swelling, minimal of the right optic nerve, but it's not impressive. It is, again, more similar to what we see in adults with typical retrobulbar optic neuritis that occurs frequently in North America and less frequently, although still happens in Asia. And if we look with OCT, just to show that in this case, the macula is not affected at all, at the right side of the cross-section, you can see that there is some thickening of the peripapillary retinal nerve fiber layer. I don't personally find scans of the retinal nerve fiber layer to be particularly useful in acute optic neuritis. It can be useful chronically. So in this case, we got an MRI scan of the brain in orbits, as one would, and the MRI shows anterior enhancement of about half to 1/3 of the intraorbital optic nerve. That's shown here as well on coronal section. There's not really enhancement of the optic nerve sheath. The stripe that you see on the axial section was the artery, and her brain MRI was normal. So of course, the question that the parents have is, will my child get multiple sclerosis? They go and ask Dr. Google, and Dr. Google tells them about multiple sclerosis before they even come in to see you. Optic neuritis treatment trial again. We know that in adults, the white line at the bottom showed the risk of progression to multiple sclerosis in patients with no MRI lesions. The green and yellow lines show you the risk of progression in 15 years with MRI lesions. This was in the pre-gadolinium era, pre-flare era. So the rate of everyone progressing to multiple sclerosis is lower now than it used to be, even with abnormal MRI. And in particular, those who have a truly normal MRI, their risk of progression to MS is much, much lower than the 25% here. But how about in children? What predicts that risk of progression to multiple sclerosis? It was thought in some retrospective studies that bilateral versus unilateral optic neuritis was predictive, or the age of onset of the optic neuritis was predictive. So there have been, I think, 2 good studies that have evaluated this, and a number of smaller studies, not that they weren't good, but these are large studies, one a meta-analysis published in 2011, and one a larger retrospective study done in 2015. Looking at these various factors, do they have a viral prodrome, how much did they recover, what did their MRI look like, did they have abnormalities on MRI, and also did they get a lumbar puncture, and were there oligoclonal bands present? And in the first study, it was suggested that 40% of patients developed MS after 4 years. And in that study, the youngest patient was 4 years old at the onset of their optic neuritis. And the median age, though, for progression to MS was much higher at almost 15 years. And there was an increasing risk of multiple sclerosis with increasing age of presentation. But bilateral versus unilateral presentation in neither study was predictive. The greatest predictor was MRI. And in the retrospective meta-analysis, it was suggested that there was a 25-fold increased risk with abnormal MRI, but not all patients in that study had MRI. In the more recent study in 2015, when all the patients had MRI, the MRI was predictive, but also oligoclonal bands were highly predictive. So having positive oligoclonal bands and or having positive MRI gave you about a 3-fold increased risk of multiple sclerosis. But the 2 together had conferred a 26-fold risk of multiple sclerosis compared to those who had neither oligoclonal bands or an abnormal MRI. So my suggestion is getting MRI and getting a lumbar puncture on these patients is going to be highly predictive of their risk of progression. Finally, this last case, a 12-year-old Black girl who was in school, and in the morning she was fine, but by the end of the day could not see her way back to class. Again, otherwise healthy, a family member with glaucoma, she's doing well in school, she has a healthy sibling and no pets. She has hand movements in one eye, counting fingers in the other eye. Her external exam is unremarkable. She has sluggish pupils, a subtle left RAPD. Though the vision was worse in the right eye, she couldn't see the Hardy-Wren-Riddler plates, of course. Her fundus examination was completely unremarkable. No optic nerve swelling, no hemorrhages, and visual field, she couldn't see the bowl out of her right eye, and the test was terminated. This is why I think OCT is not particularly useful in the acute phase. It doesn't tell you anything other than the fact that probably she's never had this happen before. More important, the MRI findings in this patient. This patient had no pain. She had no other symptoms other than vision loss. And at first, it was because she was 12 years old, it was suspected maybe this is functional, but get the MRI and do a good exam. She had an APD, it's not functional. And she had enhancement of both optic nerves in the intracranial space, and particularly going back toward the optic chiasm. So posterior bilateral avid enhancement of the optic nerve bilaterally, and the MRI of the brain itself was normal. So what additional studies do you want to get now? Well, here, a spinal MRI was done. It was normal of the cervical and thoracic spines. We're looking for the kind of abnormalities you see on the right, of course, longitudinally extensive transverse myelitis that might give us a diagnosis of a disorder like neuromyelitis optica spectrum disorder. And NMO spectrum disorder can occur in children, certainly does. There are cohort studies that have been reported. They tend to present in a similar way, and we still don't know about the role of long-term immunosuppression in those patients in terms of how long they would need to be on that, because if you start a 10-year-old on immunosuppression, are you going to keep them on that for 70 years down the road? So some vexing questions there, I think, that I don't have the answers to yet. MOG, myelin oligodendrocyte glycoprotein antibody, was actually first reported in children with optic neuritis less than 10 years ago, and of course in adults less than 10 years ago as well. And there is a crossover between MOG positivity in patients who have conditions like ADEM, acute demyelinating encephalomyelitis picture, and those who have isolated optic neuritis. And we are still learning about the role of MOG and the need for long-term treatment or extended steroid treatment in children who have MOG-positive optic neuritis, because it has been shown that only a minority of patients who have MOG-positive optic neuritis have MRI abnormalities. There's, again, that crossover with ADEM, but the need for long-term therapy is not as clear as it is with NMO. And the role of lumbar puncture, again, looking for other inflammatory disorders, looking for the presence of oligoclonal bands may be useful, even in patients like this, to try to differentiate among the potential underlying causes for this severe vision loss, and helps you to know when to institute therapy. There's a evolving literature in adults about the importance of starting therapy very quickly, corticosteroids and possibly plasma exchange in those patients who have NMO spectrum disorder, because of the poor response after even 2 or 3 days of onset of vision loss. So overall, optic neuritis is less likely to occur in children than in adults, but has a wider range of causes. The visual outcomes tend to be good, and our treatments really are extrapolated from adult studies. We don't have the same kind of prospective treatment data. MS risk in those patients with retrobulbar optic neuritis are related to MRI findings, oligoclonal band positivity, and a slight effect of age. The older they are, the more they are going to be like adults in terms of their risk of MS. You definitely want to consider other causes in higher risk patients, Asian patients, Black patients, those who present with atypical symptoms, and we can perhaps discuss the role of long-term treatment in patients with atypical optic neuritis. Thank you very much.
Thank you, Dr. Prem. We'll take some questions. The last speaker, but we do have a good panel still up. And we have Dr. Preeti.
Yeah, no, I had a question.
Yeah, Dr. Digvijay.
Dr. Prem, basically so the imaging that you do for, in pediatric patients in terms of the MRI, is your threshold very different from what you would do for somebody who's, let's say, an adolescent versus somebody who's, in the lower teens, or, an age below 10 years? Would you have a different threshold of that?
For doing MRI beyond the brain and orbits, you're asking in terms of doing the spine?
Yes.
Great question. I base it more on the clinical presentation, less on the age, because I think that if you're looking for things like NMO or MOG, then the degree of vision loss is what guides me, particularly in adolescence. So if the adolescent presents, say, with 20/40 vision, 6/12, I'm going to be less likely to image the spine than if they are 6/60. In a child, in a first decade of life, I think that there's enough crossover and high enough incidence that's now being reported of MOG positivity that I'm going to be going more for those serologies than I'm necessarily going to be going to the spine imaging first. I'll be looking for the typical features on the MRI, because differentiation between MOG and NMO right at the outset is more from the serologies than it is from doing imaging of the spine.
Right.
Prem, hi. You mentioned that in.
Yeah, you're on.
Oh, okay. That the outcome didn't seem to be different from the few studies, whether it was bilateral or unilateral optic neuritis. I was wondering, did you find anything that mentioned whether there was papillitis or not that made a difference? I always thought of optic neuritis where there's papillitis as being obviously more severe in a younger child with a stronger immune system, and that whatever caused the neuritis may be eradicated in children with such strong immune systems that we see papillitis than in older children, which have more adult-like immune responses where it's more subdued, and this can lead to chronicity.
Sure. I don't recall seeing any strong data to say that the outcomes from papillitis were markedly different. And I think that's going to be biased by exactly what you're saying, which is that there's an age effect there, that the papillitis is more commonly observed in the younger children and the retrobulbar is more commonly observed in adolescents. And when we look at the visual outcomes, we don't, we may be fooled. It's similar to the erroneous conclusion that was drawn that bilateral optic neuritis was protective from MS compared to unilateral optic neuritis, and that was more an age-related issue because younger children were more likely to have bilateral optic neuritis. So I agree with you, there may be a difference, but it may be hidden in the data.
Prem, I have a question for you.
Yes.
So several years back, the teaching was in children bilateral optic neuritis is more after a post-viral illness. And we did see lots of patients following fever with bilateral disc edemas and optic neuritis. And in general, they all responded very well to treatment. And is it still the case, or is it possible that in those cases we have missed when the biomarkers were not available, MOG antibodies? And is there still a relation between this post-viral optic neuritis and children bilateral optic neuritis?
No, I think that's still true. I think there is, Cameron just brought up the issue of that strong immune response that children tend to have, and that post-viral papillitis. I think the data still support that it exists. And one differentiator might be, that you said those children responded well to a short-term therapy and recovered well. The children who have, say, a MOG optic neuritis, which can present with a very hemorrhagic, swollen optic disc, they are going to be at increased risk for having recurrent symptoms when you taper off the steroid very quickly, because that's a more steroid-dependent disease. So to your question, I don't think we were missing many of these children in the past, because the more predominant issue is still, or more predominant cause is probably still the post-viral optic neuritis, papillitis picture.
I have a couple of questions. So it was a wonderful talk, Dr. Subramanian. One was, do you recommend getting NMO and MOG in every child with pediatric optic neuritis? Or would you base it more on what you see, for example, large segment involvement of the optic nerve or chiasmal? And two, as a corollary, would you then change your treatment? Would you just do, say, just a short course of IV with a short course of oral, or a longer taper, say, in someone who has MOG positivity? And hence, do you think everyone should get this?
Sure. Those are great questions, and it relates back to what Dr. Digvijay was asking about with respect to the imaging and such. And I don't test every patient who comes in for MOG and NMO, and because I don't think it is helpful in terms of guiding management. So I do base it in part on the features you were talking about, a long or more posterior enhancement of the optic nerve when you're talking about NMO, enhancement of the optic nerve sheath, or even spillover enhancement into the orbit in the case of MOG. It can be confusing in young children because of that hemorrhagic swelling that I was just talking about. So I think it's useful to go ahead and get MOG in them to make sure you're not overlooking it. But I would not advocate for testing in everyone. And along the same lines, if the patient presents with very poor visual acuity bilaterally and they have long posterior enhancement, I am concerned for NMO, and I will be more aggressive in terms of my initial treatment. But otherwise, the treatment strategy is, I do start almost all patients who don't have a contraindication on the intravenous corticosteroids once we've excluded an infectious cause, if that's high concern. But then we are fortunate to get the lab results back fairly rapidly to help us to guide if we need to transition over to a more aggressive treatment like Plex.
And what about CSF testing? Would you get a CSF on everybody?
We do get CSF testing on the majority of patients, especially now because of the predictive value of oligoclonal bands that have been shown in the adolescent patients. So there's a very low threshold for getting CSF on these patients.
So thank you, Dr. Prem. I think the whole panel is quite exhausted, especially bulk of them are in India, so it's getting late, I think, past their dinner times. So hypoglycemia is also causing some neurological deficits here. So I think I would now take the opportunity to thank all the esteemed speakers. It has been an outstanding presentations by all of them. The discussions have been excellent, and thank you all the speakers for staying till late and contributing. Thank you, everybody. Thank you, panelists. And we have Professor Namrata Sharma, who's the secretary of the AIOS. So I would thank her for giving us this opportunity. Final words, Dr. Namrata.
Oh, thank you, Rohit. I need to thank all of you. I need to thank you for coordinating such a wonderful program. And thank you, Dr. Pradeep Sharma, sir. Thank you for always gracing the platform for us, and all the speakers from different parts of the world, and all the panelists from not only across India, but from all over the globe. Thank you so much for making this happen.
Thanks.
Thank you.
Thank you, everyone.
You all.
I learned very much.
Thank you. Thank you. Goodbye.